Oh, it's Dell. Okay.
Yeah.
Okay, then we should be good. So I just wanted once we actually start reviewing the cases for the transitions to go fairly smooth. All right, Dell. All right, and a shout out to Prodigy and the Prodigy staff. Dr. Pinkham, thank you for helping distribute everything to all these people. So I think we probably have quorum. We have enough people waiting, so we're going to get started. We have 3 very interesting cases. The first one is going to be from the US, from South Carolina. Dr. McKinnon, who's one of the senior residents. She's not a beginner. She also has a PhD actually in MRI physics and diffusion imaging of the brain, but she's been branching out to cardiac imaging and has been enjoying that. And so we were working together the other day and we saw this interesting case, which is probably worth looking at because the findings are kind of elusive and difficult to see. And you really have to look carefully and look at the CT scan in a specific way to see the findings. That will be followed by Dr. Tariq showing us a really complex congenital case that'll make your head spin, probably. It did that for us. The case was actually first shown to me by Dr. Limo from Dar es Salaam. And then if we have some extra time left, then I might show a really crazy case. So if your head is not spinning after the first 2 cases, then by the third case, it definitely will. And if it's okay with everybody, I'm going to start the recording as well. And
I think it's already recording, Dr. Sarani. I had got a message earlier.
Was it?
Yes, or somebody.
Oh, it's being recorded. Okay.
Yeah, it's recording.
All right. Maybe it was set on automatic. Okay, then I have to stop speaking and turn it over to Dr. McKinnon. And for those of you who are not speaking, please, if you could mute yourselves so we have less noise in the background. Thanks very much.
All right. Well, thank you, Dr. Sarani, for asking me to present this case. I'll try and do my best. So we were working together on Monday, and we had a 15-year-old come in who already had some cardiac history. He had middle aorta syndrome with known clots in the descending thoracic aorta. He also has a known history of moyamoya disease and resistant hypertension. He came in with elevated blood pressures. It was like around 170, 180 systolics, as well as kind of intermittent chest pain. The note says that he had been having some chest pain intermittently with exercise, but it was getting more severe, prompted them to present to our emergency department. So the primary team obviously got some troponins and EKG. EKG did show some ST depressions, and troponins ended up being positive, peaking at around 350. It was, I think, a day or 2 later after he presented. So the cardiology team got involved and they wanted us to see if he had some sort of coronary artery occlusion or any cardiac ischemia secondary to some of his underlying conditions and obviously the symptoms he presented with. So we got a CTA of the heart. It was
Please
done.
share your screen.
Yes, I will. It was done since it was a pediatric case. We have kind of a protocol that is done for low with like less radiation, so it's a little bit more grainy than our adult cases. But with that, I will kind of walk you through the findings. Can you guys see it? Can you see it, Dr. Charney?
Yes, we can see it.
All right. So I'll just start with the axial view of the heart here. Since we were looking for coronary artery occlusions, we'll just start by looking at the coronaries. we'll start with the RCA, which was patent. It gets a little bit diminutive there, and then the circumflex also actually was patent all the way through, from here to the back. And then the LAD was kind of where we initially had some questions. It gets a little bit like hard to see around, this area, and there might be some myocardial bridging right here, but then it does reconstitute. So initially, when Dr. Sharani and I talked about it, we're like, oh, it's this motion. Could there be some sort of a blockage here? So then we ended up making some actually some average projections, and looking at it in motion. So I'll show you the images that Dr. Sarani nicely made of. So here is the LAD throughout the cardiac cycle, and it's also so averaged. It's probably about maybe 2 millimeters to kind of get rid of some of the noise. And you can see in this branch, there is still this area that's not as well opacified here as well, that, made us think oh, well, maybe there's something there. So obviously this prompted us to kind of go look at if we could see any hypoattenuation of the myocardium, or if there was...
If I may interrupt, just what's the other branch right next to it?
Yeah, I think it's a diagonal branch, that kind of branch. Oh no, is it a vein?
Yes, I think it's the anterior interventricular vein. Yes.
Yeah.
So just for everybody else's sake. So yeah.
Yes. So this one is the LAD, and this is the vein.
Yes.
And so obviously here we were already like, well, maybe there is some sort of occlusion. So we wanted to look more at to see if we can see any other signs of ischemia, like hypokinesis or hypoattenuation. So let me change you to my other screen. Let's see. Your screen number 2. All right. So can you see the NPR?
Yes.
All right. So so here again, this is the 3 cardiac planes, short axis view. And I also, again, kind of I did a little bit of an average of a few slices to just kind of show this better, because it's grainy and makes it a little bit more difficult to see. But I hope you can appreciate that kind of here in this anterior wall, it definitely appears that there's some hypoattenuation in the subendocardium, and then here as well in the, I guess, this long axis view, this wall right here is a little bit hypoattenuating. And I'm going to scroll down a little bit on the 2-chamber view, because you can definitely tell when it gets closer to the apex, it kind of becomes all circumferential.
Yes. And then higher up at the mid-ventricle and the base, it's more like anterior wall and anterior septum too, right? So it's very reliably LAD territory. So maybe point out the anatomic landmarks between the anterior wall and the septum there.
I guess this right here where the right ventricle.
Yes.
Yeah, so here it's kind of in this whole area right there. And then when it gets closer to the apex, it kind of comes all the way around, which, like Dr. Sharani says, is kind of reliable, like suspicious for LAD ischemia or some supply and demand mismatch. Obviously, the other thing that I think is worth pointing out from these views is that, so this is a 16-year-old, like you can tell, like there is definitely some left ventricular hypertrophy happening, which he did have a known diagnosis of, given the history of just longstanding hypertension and kind of clots in the aorta. So that's one thing. And then, do you want me to do motion now, or do you want to talk about the other findings while we're in this view?
Well, it's up to you. It's up to you.
Okay. Well, I guess while we're here, before we move back to the other screen, I think it's worth pointing out that he has, I think, I mean, it's a little bit difficult to see, but so he has this accessory tendon. Can you feel you can see it from this view?
If you go down one more slice on that view, just one more, right there, stop there. You can see, point out that papillary muscle, right?
Right.
And then it has a chordae tendineae, or a false tendon, right? That one that's attached to the septum,
Right.
right?
So
That's never normal in the left ventricle, definitely, to have a chordal attachment to the septum, right? The chordae ought to attach to the mitral valve leaflets.
mhm.
Mhm.
So we noted that this is causing some extra obstruction in systole. Obviously, it's like it's causing a lot of this blood not to be able to be ejected in systole, and causing just like increased obstruction above the hypertrophy that he already has. And he also has it's difficult to see here, maybe we can see it better in motion, but some version of SAM where during systole there's obstruction of the LVOT
And if you could
because
point
of
out what, or detail what SAM is.
Yeah, so I guess it's a systolic anterior motion of the leaflet of the anterior leaflet of the mitral valve. So because of the septal hypertrophy, and when the heart contracts, it causes some outflow obstruction, where the anterior leaflet is kind of the mitral valve is getting pushed in front of the LVOT. So there's not as much blood getting out of the aorta, to the aorta. Did I do that justice?
Yes, excellent. So if you could scroll up on the short axis view to the level of that false chord, right there, and you can see at that level, I'll go back down a little bit. So just find, this is sort of an end systolic phase. On the top right corner, you can see it's best systole. It's 43% of the cardiac cycle, so it's probably near end systole. So you can actually, on your short axis view, find the spot where the chamber is the smallest. So if you scroll gently up and down on your short axis, go down to the apex more. And right there, yeah, right there. And you see that where the chamber is at its narrowest, that's precisely the spot where that false chord is coming across on the four chamber view. And you can also see confirmation on the two chamber view on the bottom left that is the spot where the chamber gets very, very narrow. Can you put your arrow right there? Exactly.
Yeah.
Right. So it's a multifactorial obstruction. It's an obstruction from the thickened myocardium on the one hand, the thickened papillary muscles, they get crowded, and the trabeculations, and you have a false chord. So all of these things coming together to cause a mid-chamber obstruction, a severe mid-chamber obstruction. So the apex partly gets trapped, and in this kid who's already hypertensive, like you mentioned, the kid presented with sort of a hypertensive emergency, right? The pressure they measure on the kid is the systemic arterial pressure. The pressure that will be present in the apex of this obstructed left ventricle is higher than that. So if you have a pressure gradient of, let's say, 50 millimeters of mercury through the mid-chamber, and the kid has a systemic blood pressure of 170, that means that the apex of the left ventricle is experiencing 220 millimeters of mercury, right? So add to that this hypercoagulability and this potentially compromised LAD, and like you said, it may be truly an occlusion of the LAD or a thrombosis of the LAD, or a combination of decreased supply and increased demand and the increased pressure in the left ventricle. So all of these factors working together, it's very likely that there is actually acute or subacute ischemia and maybe even infarction going on.
Yeah, and so I'll show you some of the last thing in motion. Let's see. It was very subtle, but if you really focus on the LAD territory, you can notice.
Very good.
All right, let's see. Can you guys see this move? See if
Yeah,
I
just
can-
scroll slower because the refresh rate is not as fast on Zoom. So
Okay.
that's very good.
So this anterior wall, it is a little bit interesting because in this view, it kind of looks like this interior wall is actually thinner than the other side. But when we looked in, at end diastole, it looks like it's an absence of thickening more so than a like indication of a chronic infarct where there might have been some dying of the myocardium.
You can actually scroll to the end diastolic image, right? Like you can stop where. Yeah.
Let's see.
Yeah. So there's relatively less thinning at end diastole. It looks more quote unquote thinned on the systolic images, and that's also an important teaching point indeed, that when you're assessing wall thickness per se, you have to check the end diastolic images. Otherwise, you might think if you're just looking at systolic or mid diastolic images, you may overestimate the degree of thinning, and you might think that there is a chronic infarct there as opposed to acute ischemia.
Right. And so here I think it's well seen somewhere at mid systole that this part of the wall is not thickening as much as this part. It is still subtle, but you can tell. Again, pointing us towards that there's something in the LAD territory that this wall is not getting enough blood. And let's see if we can look at it in the long axis. Let's see.
You can beautifully see that all standard obstructing in the middle.
Yeah, like right here.
No, so
That's it.
going across, there's a line across. If you go stop there, stop at end systole, right there. What you're pointing to, that dark line connecting the papillary muscle to the septum.
Oh, right here. Sorry.
That's the one.
Yeah.
Yes, that's the one you need to pay attention to. Yeah, exactly.
Oh, because right here is the mitral valve leaflet.
Yes.
So
Yes.
I see that.
Yes, excellent. Right, and if you put it on a window a little bit sharper or narrower window, you all will hopefully appreciate even better the hypotension that Dr. McKinnon was pointing out in the anterior septum and the apex and portion of the anterior wall. Yeah. And that persists throughout the cardiac cycle. So that's another potential pitfall when you're reviewing these images. If you only have one frame, one phase of the cardiac cycle, it's sometimes difficult with motion artifact to tell how much of this hypoattenuation is real or not. But when you see a hypoattenuation like this case persisting throughout the cardiac cycle, you can be more certain that this is a real finding. So it actually took us a little bit of time to convince our cardiology colleagues that this is a real finding. But I think once we did the proper reconstructions and some of these tricks that Dr. McKinnon was showing us, averaging, virtually thickening up our slices to reduce some of the noise, or to visualize the coronary using a MIP. Those are tricks in post-processing that are very, very helpful. And of course, lining things up with the dedicated cardiac planes, like we also talked a lot about last week in Indonesia on our MR workshop, that getting the proper cardiac planes is always going to be very important in assessing cardiac findings, and going to the right phase of the cardiac cycle, like Dr. McKinnon was pointing it out when we were assessing wall thickness, for example.
And so in this particular case, we recommended, so the cardiologist made obviously the great point that since he has a very small aorta with clots, they didn't want to jump straight to go to the cath lab. So we recommended them getting a MRI of the heart to kind of assess just like the fibrosis or any of or hypoattenuation using gadolinium to see if this has been acute or subacute or chronic or
excellent. By the way, could you pull up an axial set of images and show that clot in the aorta just for everybody's sake?
Of course. Yes.
Just a big overview one. Yeah.
It's just kind of popping right there.
Yes.
So you can also tell, so this aorta is very small.
Yes.
So
multiple clots. Yeah.
And there's one right here.
Maybe show the
more-
sagittal view just so everybody can see the sort of the extent.
Yep.
It's
I
sort of
will
in the,
do
yeah, that one.
Here we go.
Yeah, there you go.
You know, risky for this child.
Yes. it is. Yes.
So
Unless,
we did not get the MRI yet. Maybe they'll do it outpatient. So this actually, so they treated this patient's hypertension, and symptoms got better. The troponin went down, so it might be something that's transient, based
Mhm.
on like a supply and demand of the myocardium.
maybe on one of our future sessions, if we get MRI, we can follow up.
Yeah, and
Excellent presentation. Thank you very much.
you're very
I think
welcome.
this was very, very clear and beautifully presented. I think we're going to hold questions to the end in the interest of time. And we're going to hand it over to Dr. Tariq. If you could hand it over to the Dell
I already
participant.
did. Well, thank you very much for your attention, everybody, and nice to meet you.
Great presentation. Thank you very much. Dr. Tariq, the floor is yours.
Thank you so much, Dr. Pal. I tried to share my screen
Yes,
already.
we can see it. Excellent.
Amazing, amazing. All right. So this was a 1 years old child who brought into the department with history of difficulty in breathing with cyanosis. And upon echocardiogram, which was conducted, they thought the baby had a single ventricle with transposition of great vessels. So they sent the child straight forward for a cardiac CT for further delineation of the anatomy. Now, looking at the CT, I would love to start from not from the cardiac part, but I will start ruling out the situs part from the abdomen. Now, upon looking at the liver itself, the liver was centrally located, with no any visualization of the spleen. The stomach was seen to be much more oriented on the right side. And following up upon the hepatic vasculature, the central hepatic vein and another part of the hepatic vein was joining up to form a common trunk, which was draining directly into the right atrium. But on the other side, looking at the left hepatic vein, it was draining into the IVC, and the IVC seemed to drain directly into the left atrium. Coming upon the atrial anatomy, as you can see, the left atrium was seen to be having a broad-based appendage. The same applied to the one on the right. All right. That's the right-sided appendage. It was also much more bigger in comparison with the normal finger-like appendage, the one that is actually normal, with the possibility of a PF4 at the region. Coming upon into the left, into the ventricles, there was a big VSD, multiple VSD actually. That's one of the first VSD around there. There's another VSD just around the apex, which was noted. Moving ahead, looking at the great vessels, as you can see, this is our right-sided ventricle, and that's our left-sided ventricle. And coming into the great vessels, this is the first one, which is the pulmonary outflow tract. As you can see, it's originating directly from the right ventricle. It's a little bit narrowed at the pulmonary outflow trunk with hypoplastic pulmonary valves. The right-sided pulmonary artery and the left-sided pulmonary artery had got good calibers though. Then looking upon the aorta, well, it was also originating from the right side. That's our right ventricle. That's our aorta. That's the aortic outflow tract. It was a left-sided arc with good 3 branching patterns. Then going into the veins, looking upon the pulmonary vein. So that's the first, the right-sided vein. The right-sided pulmonary vein was joining up with the left-sided pulmonary vein. They were all two draining into this vertical vein, and the vertical vein was ascending up to come and drain directly into the left-sided superior vena cava. And it is from the superior vena cava, which was left-sided superior vena cava, coming down to drain into the left atrium. We had, as you can see, the right-sided subclavian was coming straight forward to join up with the left-sided brachiocephalic vein. Well, apart from that, I would summarize it up shortly. So coming ahead, first was the liver itself, centrally located, with the right side and the central hepatic vein coming to join up into a common trunk, draining into the right atrium. Coming into the other left-sided hepatic vein, it was draining directly into the IVC, and the IVC was draining into the left atrium. The atrial appendage were broad-based, making it a possibility of isomerism. The ventricles, the right and the left ventricle. The left ventricle was in its morphological left side, and the right was on the morphological right, with multiple VSDs. Coming into the main vasculatures, the main pulmonary artery was originating from the right side, with a narrowed pulmonary outflow. The aorta was also originating from the right side, making it a double outlet right ventricle. It was a left-sided arc with 3 branching patterns. Coming into the veins, the right-sided vein and the left-sided vein were all draining into this common vertical vein, and the vertical vein was draining directly into the left-sided superior vena cava. It is from the superior vena cava which was seen to drain straight into the left-sided atrium. I think that's it for this case.
That's very good and excellent presentation. Thank you also for scrolling very slowly. I think it was, at least from where I was looking, it was very easy to follow, despite the fact that this is an extremely complex case. Definitely excited, ambiguous, and looks like right-sided isomerism. Perhaps if you could show us a coronal view just for everybody's benefit, so we can take a quick look at the airways.
All right. I will take one here. All right. All right. Let me put it into lung window.
Mm-hmm.
All right. Is that okay?
Yep. Yes, looks great.
Good. Okay. So that's the trachea coming in. That's the bifurcation, the right-sided bronchi passing underneath the pulmonary artery. That's our upper segment right there.
That's the superior segment of the lower lobe, yes. But I think the upper lobe might be coming up early. If you go right, no, go back there.
Yeah, this one here.
Yeah, so that's probably above the pulmonary artery, right? So ap arterial on the right.
Yeah.
So aporterial would mean above the right pulmonary artery. So the right upper lobe bronchus coming above. Yeah.
All right.
And then the left side.
The left side was a little bit challenging.
Yeah.
Yeah, oh,
Certainly
as you can
harder
see.
to tell. Yeah.
Yeah.
It's probably below, I think.
Yeah. Yeah.
More like posterior. It's hard to tell on the left side. And sometimes this is going to be hard to tell, I think.
All right.
I don't know if anybody online wants to chime in this particular case on the left side. If there are any clues. If you scroll slowly back and forth on that left upper lobe bronchus area.
Hi.
I'm seeing something else here coming above. Like, hello, Dr. Limo.
Yeah, I wanted to suggest. So sometimes what I usually do, I try to change the planes so that they
Mhm.
follow the anatomy of the airway. Like if you have like a true coronal, because of the orientation of the heart and chest, it might be challenging. So sometimes what you do, you kind of make like something like oblique coronal, and then you navigate through the airways using the line, and you might get lucky and see how the airways are oriented. That's my contribution.
Uh-huh. Yeah, so if you
Okay.
go into an MPR view, perhaps, I don't know if you can do that, right?
Yeah, sure. Should I? Okay, can I? Okay, let me use this one to construct, if that's okay. Okay, so let me put this into the lung view. Okay. All right. I hope that's okay. Okay, so we are getting much more difficulty into the left side. So I will go straight into the left side.
Turn the red line, yeah, but also turn the red line on the coronal, on the sagittal view. Go back to your sagittal view and turn the red line counterclockwise.
Okay.
Yeah, something like that. And then maybe on the bottom left, make it a little bit more horizontal. Bottom left image.
Okay, bottom left. Okay.
Make it more, yeah, just like that. Yeah.
Great.
Mm-hmm. That is very helpful indeed. I think it does look like the left side is going under, the left upper lobe bronchus is going under. So
yeah.
So I think the lung situs, pulmonary bronchopulmonary situs is actually normal here.
Mm-hmm. All right. Thank you, Dr. Limo. Thank you, Dr. Pal.
Yeah, thank you guys. This is
no problem. Thank you.
Excellent. Excellent.
All
I
right.
think in this case, there was just one more thing that I wanted to point out that's really hard. If you go back to your axial images, that
All right.
I do remember Dr. Limo and I were kind of a little bit puzzled about, but it's just something that I'd like to highlight. If you scroll down to the left ventricle and keep going slowly down, keep going, stop there. So there it looks like there's maybe go back a couple slices up, just a couple slices upwards, scroll up, keep going, and stop on that one. Yeah. So there's that, what looks like almost like a moderator band on the left side of the ventricle, not that one, more to the apex. Scroll down one more slice. Yeah, that one near the apex, and it's hard to tell sort of whether that's a portion of the interventricular septum, or is it a moderator band in the left ventricle? See, near the apex, if you could point it out. So that's a papillary muscle, but to the just next to it in the middle. Yeah, that's that one.
Right.
Back between the two. Just that one. Yeah, that's the one. So if you scroll
Alright.
up and down on that one, just gently, slowly, so everybody can kind of see it scroll up and down on that one. That looks like a moderator band that's going to the left side. And that could be confusing in some of these cases because some patients will have a muscle band that connects the left ventricle, morphologic left ventricle lateral wall to the septum. And the moderator band in general is a very useful feature and is a very, very important feature we look for to identify the morphologic right ventricle. But sometimes patients don't read the books. That's what I usually tell my trainees, and will trick us and trip us up by having structures that will make us wonder. But I still think that the left-sided ventricle in this case was still the morphologic left ventricle, because the rest of the leftward aspect of the septum is actually very, very smooth. And that would be more of a left ventricular feature. And then we see that the right-sided ventricle is overall more trabeculated. And then it gave rise to the two outflow tracts with the muscular infundibulum. So it still looks like this is a left-sided left ventricle and a right-sided right ventricle. But sometimes things will get very tricky, especially in a case like this when we have big ventricular septal defects. So thank you very much for the presentation and the excellent case to both Dr. Limo and Tariq. And if you could transfer the host to me, then I will show you another really crazy case that I came across. It's just a 2-day-old.
Done already.
Yep, thank you. So hopefully you guys can see my screen. This is a little 2-day-old where we will start from the very, very top, slowly scrolling through, and then we'll go more in sort of a segmental manner. You can see definitely very, very confusing anatomy. So if you go from the abdomen, it seems like we do have a spleen, we do have a left-sided stomach, we do have a right-sided liver. We see an umbilical venous catheter here that presumably is in the IVC. We don't have a lot of contrast in the IVC, but that would be in the IVC. We here, actually, as we get closer to the heart, we get a glimpse of the IVC. We also see a little bit of a coronary sinus. And we have a right-sided atrium here that's kind of smaller, and definitely see a interatrial septum that's rightward bulging, indicating left atrial hypertension. But we have a right atrium that accepts both the IVC and the coronary sinus.
Recording stopped.
And then we also have a right-sided superior vena cava that's not very well opacified, but we have both brachiocephalic veins here as well. So it seems like the systemic venous return is probably going to be normal. I will admit that right here at the superior cavo-atrial junction, it seems like there's a little bit of compression of the cavo-atrial junction to the right ventricle or right atrium due to this bulging interatrial septum, but I still think that the systemic venous return is essentially normal here. So we have a right atrium, and then we have a communication that's slightly narrowed to this ventricle. We'll get back to the ventricles in a second. That's kind of funny looking. The ventricle that's kind of more caudal. And then if we scroll upwards, we will see this other ventricle. That's very peculiar. Like I said, we'll get back to the ventricles. Since we were at the level of the atria, let's finish up with the atria. We're going to look for some pulmonary veins, a right inferior pulmonary vein over here. We have right superior pulmonary veins coming over here. Obviously, a massively dilated left atrium. We're going to find the superior veins on the left side as well. Here we have some superior pulmonary veins coming in, and further down we have some inferior pulmonary veins. They almost seem to be joining into one big common vein, and that's not actually very unusual on the left side. And then this enormous left atrium also has this big thing, which, believe it or not, is the left atrial appendage, and it's very elongated with a distinct neck. So definitely has left atrial appendage morphology, whereas on the right side, we saw this very widely broad-based right atrial appendage, sort of confirming for us that the morphologic right atrium is on the right, the morphologic left atrium is on the left and posteriorly. So as far as the veins and the atria are concerned, it seems that things are in order. Perhaps let's take a quick look at the bronchopulmonary situs as well before we turn our attention to the ventricles. And what I'm going to do here is I'm going to go into MINIP. Like you saw earlier, we sometimes like to tinker with the reconstructions a little bit. If you go to an average or a thick MPR by some other softwares, then you can virtually thicken up the slices to make things look less grainy, like in this case, you can see that. If you're following vasculature, you would use the MIP, which is a maximum intensity projection, then your vasculature will be easier to follow. But in this case, since I'm looking for the airways, I'm going to go into MINIP, which will accentuate low density structures. So, and hopefully this way we can see that the right main bronchus comes here and very quickly gives off the right upper lobe bronchus, which is going to be an eparterial bronchus. And then we see the bronchus intermedius on the right side. Whereas on the left side, we see a very long mainstem bronchus, which unfortunately is a little bit compressed by our massively dilated left atrium, but we can still appreciate that the left upper lobe bronchus kind of crawls underneath the left pulmonary artery, which is over here. This is our left pulmonary artery, and the left upper lobe bronchus is underneath. So we have a hyperterial left upper lobe bronchus and an eparterial right upper lobe bronchus. And so it seems like the bronchopulmonary situs is normal, as was the abdominal situs and the atrial situs. So as far as that is concerned, everything seems fairly normal. Now comes the trick, because if we carefully watch these two atria and the atrioventricular valves, which would be coming in here, we know that they are kind of rotated and they are actually coming into these two ventricles, which are upstairs, downstairs. So this is a very rare formation or conformation of the heart. This is called crisscross heart, also called upstairs, downstairs ventricles, superior, inferior ventricles. People use various terms for this very rare configuration. But what we see here is that this very dilated left atrium is actually primarily draining into this upstairs ventricle, and this smaller right atrium is draining into the downstairs ventricle. Now, morphologically, if you look at it, it seems that the downstairs ventricle has a smoother aspect of the septum, as opposed to the upstairs ventricle. Septal aspect is more trabeculated, as you can see here. And you can see a moderator band here on the upstairs ventricle. this all will be probably better demonstrated if we go into a dedicated MPR view and try to line up with the long axis of the heart. But it's really, really difficult in this case because things are so backwards. But we will attempt it nonetheless. And then what we will also be able to appreciate this way is that both of the outflows are coming out of the upstairs ventricle. So it's and the upstairs ventricle is going to be a right ventricle morphologically. So this is going to be a double outlet right ventricle. So trying to get into a view where it's easy to demonstrate inflows and outflows. So perhaps this view then is a nearly perfect short axis view as much as that's possible here. But you will see that the ventricle's orientation is sort of this way, whereas the atria are kind of this way. And the AV valves, here's one AV valve, and here's another AV valve. So they're kind of this way. So everything is sort of crisscross, rotated across from each other. And that what you can appreciate is this is our septum, which obviously there's a huge septal defect, which is the saving grace for this child, because that allows mixing of all these different kinds of venous blood. And then, but then both of the outflows are coming from the upstairs ventricle here. So you can see both the aortic and pulmonic valves here. And then if I go into a sagittal view here, it's going to be also another curveball that what you think is the aortic arch is actually not the aortic arch. This is a ductal arch, because this kid, on top of everything else, also has an interrupted aorta, or it's nearly completely interrupted. So now we're going to follow vessels. So I'm going to switch to a MIP view and make it a thin MIP. That will give us better quality images. So we can see here from this upstairs ventricle arises the aorta. This is the ascending aorta here. Gives rise to the arch branches over here. But then this arrow actually shows the severely narrowed aorta, which it's not truly completely interrupted. It's severe coarctation, but it's a near interruption of the aortic arch, distal aortic arch. So this is our actual native distal aortic arch connecting to the descending aorta, which is here. But the descending aorta is primarily supplied by this large patent ductus arteriosus. And then you can see that from the main pulmonary artery comes the left and the right pulmonary arteries. So this is actually a ductal arch and then a fairly nicely developed descending aorta. So really a very, very unusual case with upstairs, downstairs ventricles, a huge VSD, double outlet, more superior right ventricle, an interrupted or nearly interrupted aorta with a large patent ductus arteriosus. And looking at the echo report, this patient actually also had very severe problems with the atrioventricular valves as well, significant regurgitation. And as you can see that this massive left atrium is actually primarily draining into the upstairs ventricle, into this right ventricle with the extensive trabeculation and moderator band. And this then therefore is going to be a tricuspid valve, right? Because the AV valves develop from the ventricles. So if you can identify the ventricles morphology as morphologic right, then it's very, very likely that the AV valve is going to have tricuspid valve morphology. So this tricuspid valve is actually severely regurgitant. And then down here, you see from the right atrium, you have a connection to this downstairs left ventricle, which was actually more of a mitral morphology valve. So rather crazy complex case. Hopefully you were able to follow along. If y'all have any quick questions, then we would love to try to answer them or ask for the collective wisdom of the group to try to answer it. And otherwise, I just thank you for your attention and really appreciate all of you showing up. And before all of you leave, wanted to just put it out there that next week we will not have a meeting, but in 2 weeks we will come back with full force in collaboration with Prodigy in Indonesia, and we're hoping to make these case reviews more diverse and more interesting by not just Dr. Amal or myself presenting cases, but like you saw today, Dr. McKinnon, Dr. Tariq, and others from Indonesia will probably present, or also from MUSC, maybe even from cardiology. We can get some presenters to have more people involved and more people showing cases and encourage everybody to ask questions and have an actual discussion on these sessions. Thank you very much once again, and I'm going to open up for questions if anybody has any questions. And that includes questions to the earlier presenters or earlier cases as well. Thank you very much.
There's one in the chat.
Yeah. Yes, please. Dr. Pinka, go ahead. We can't hear you, Dr. Pinka. Mm-hmm. 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 Excellent questions. Dr. Tariq, would you like to address it?
I think it would be better if you take it along, Professor Pali. It's I would really appreciate
Okay.
that.
So yeah, so I think in both of our cases we can say with fairly big confidence that MRI is not ideal because at such an early age and small children in such state usually cannot tolerate our MR scans, and their heart rates are probably too high, their structures are too small. So currently our MR technology is not that good that we can image hearts with such high heart rate and in such small children. So typically there's nothing else available really than echocardiography, invasive catheterization, and CT. So obviously all of these children will have had an echocardiogram already, and then the next best step before doing something invasive is going to be cardiac CT. And I'm going to share my screen for just a brief second, because actually at our institution, we usually document in some way the type of scan that was acquired. You can here actually see the DLP is only 2 milligray centimeters, so extremely low radiation dose. We use a KV of 70. So thereby you can really reduce your radiation dose in these children. We hand inject, so we do not use power injection in our babies, and we use the IV that is available, and this child had a right foot IV line available, so it was gently hand injected by a pediatric cardiologist, and then we scanned with an adaptive sequential way, which is EKG synchronized, prospectively triggered, so we did not blast the whole cardiac cycle, but just one phase of the cardiac cycle. And even in kids where the heart rate is in the hundreds or 120, we can often catch the coronary arteries, or at least the origins of the coronary arteries, fairly reliably. And here you can actually see that one of the coronary arteries is more posterior here, and the other coronary artery is actually more anterior right here. So you can get very lucky with these scans in children, and just gently hand inject, use a very low KV, gentle radiation, and still attempt EKG triggering if you have the scanner technology. Granted that this was done on a dual source scanner, which those scanners have higher temporal resolution, and that's if you have that available, then that's definitely helpful. But that's how I would summarize the technique. And of course, you can do bolus tracking, a single slice every second during the contrast injection, and watch the contrast hit the descending aorta, and usually that's the time point when we hit, and most of the time either manually start the scan or put a region of interest into the descending aorta and catch the contrast bolus as it's entering the child. So that would be the brief summary of the technique. Very good questions. No problem. All right. I think everybody needs to get on with your days. So if you could turn on your camera for a second so I can take a screen cap for posterity and to recruit more people in the future for our following meetings. Like I mentioned, hopefully in 2 weeks, we will see everybody. I want to thank you for your attention. I guess I should turn on my camera too. And special thanks to the presenters, Drs. McKinnon, Dr. Limo, Dr. Tariq. And we hope to see everybody in 2 weeks. Thanks, everybody. Have a wonderful weekend. And
Thank
for
you.
those of you
Bye.
celebrating Ramadan, happy Ramadan. Take care.
Ramadan to you too.
Thank you. Bye-bye.
Bye-bye.